Have you ever had your medication denied by insurance? Don't worry, you're not alone. We're breaking down everything you need to know about navigating health insurance approvals, from understanding what your doctor is doing to try and get you that medication approved to appealing denials. We've got you covered. This episode is made in partnership with the Allergy and Asthma Network and is a collaboration with the National Association of Medication Access and Patient Advocacy, also known as NAMAPA. We thank Amgen for sponsoring today's episode.
You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. All right, you guys, we are talking about insurance. Now, I'm going to preface this by saying that I live in Germany and I am a Canadian. So I am not the best person to talk about insurance when it comes to the US, but I'm going to be navigating it with you. So if any of my questions are like totally bizarre, it's because I'm coming from a very foreign spot and maybe that's helpful. We'll see. So we're joined by Lacey Varnon. Welcome, Lacey. We're very excited to have you and to talk about insurance and more specifically, what happens if your insurance claim is denied. So before we jump into all of that nitty-gritty stuff, we'd like to know a little bit more about you, Lacey, and the organization you're representing called NAMAPA.
Awesome. Well, thank you all for having me. My name is Lacey, and I am the Vice President of NAMAPA, which is the National Association of Medication Access and Patient Advocacy. It's a lot right there in a mouthful. We're a nonprofit society that was created to develop this community that sort of didn't exist yet. So it's a community of healthcare workers from all different backgrounds in healthcare, from pharmaceutical to private practice to even specialty pharmacies. And we all kind of come together with this idea of networking and being able to share ideas and educate and provide support to others out there.
I am so excited about this episode because insurance is really a big deal for providers and patients, to be honest with you. And so I think today we're talking about the patient aspect. And then we're going to have another episode that kind of focuses on the provider aspect and what providers need to know. And so I'm sure that they're going to merge a little bit, but I think this is such an important topic for people because it can really change the way your healthcare journey goes for a lot of people, not only in the medications that they end up getting, but also in their experience of the stress related to navigating a chronic illness. So to start off with, what is your organization doing and what problem is it solving for?
Yes. So NAMAPA in general, we are a group of healthcare professionals. Our main goal is to provide those resources and education. So most of the time, people who are put in sort of a care coordination role or medication access role have not been given a lot of guidance or instructions on how to do that position. It's sort of learn as you go. So a lot of us have had several years that we've had to make our own way or learn these different avenues. We've combined our experience as well as working with payers and providers and learned really a better pathway and almost to be able to provide sort of that rule book and those resources available to people who, again, just did not have them before.
Now, I've heard this word come up a bunch since we've been doing our biologic series, and I don't know if it's just because I'm a foreigner, but I hear the word payer a lot. Is that something that patients know what that means? Do they know what a payer is when we talk about a payer?
That's a great question. Maybe not. And I think that's a big thing. It kind of goes to the lingo, right? So when we say payer, we mean the insurance company. But again, many people just know it as their insurance. They don't necessarily know that terminology of payer. So I think that's a great thing to have to elaborate on or just educate as we go. I think it's a huge assumption that even when we're talking to one another, not all healthcare workers understand sort of that glossary of terms as well. I always try to approach it with speaking to someone as if they've never heard any of it before. So you kind of have to back down your language a little bit to really fully describe what's happening.
So Lacey, I think to start this conversation, what would be really helpful is just to talk about how a patient comes into the office. They need a medication. It's determined by the doctor that this particular medication through shared decision-making, meaning we've talked about all of our options and both the patient and the doctor have come to this determination that this may be the best medication. In that process of shared decision-making, I find that a lot of people talk about looking at what might be covered by the patient's insurance versus not, and thinking about that right off the bat. How do you think that we can make that process easier?
I encourage patients to bring a copy of their formulary with them when possible. Because again, that's something that they're provided by the insurance company that the office does not have a direct access to on hand.
Can you clarify what a formulary is?
Sure. So a formulary is for a pharmacy benefit. Okay. I think that's important to harp on. There is two different types of your insurance. You have a medical insurance, which most people just consider their insurance. And then you have your pharmacy benefit plan through that insurance. A formulary is going to be on that pharmacy benefit side, and it's going to be a list of medications that are covered under your plan. So a list of medications you were able to get based off of your insurance plan.
So basically, the formulary helps you and your doctor see whether a medication that they hope you can go on is actually covered.
Yes.
If you asked me, bring your formulary, I wouldn't know where to find that information.
Yes. So your insurance company in itself should be sending you that information. It should be coming in like a membership book most of the time, or you should be given information on where to access that. So a lot of this happens in open enrollment time. So what open enrollment is that time period in the fall in which you look at changing your insurance company or changing your insurance plan for the next year. So as you enroll in those insurance plans, then that company would be reaching out to you and providing you with all of your information that you're going to need. So that's where that kind of comes back into play. The patient should have a copy of all of that on hand or the instructions on how to gain access to that.
Yeah. And I think the world of online everything, I'm assuming that if I went to the website, I could probably find that information on my patient access portal.
Mm-hmm.
And then that formulary, because there's thousands, millions of medications out there, would be divided up based on condition.
Mm-hmm. You're exactly right. And if you just skip to the very back of it, into that index section and find my exact drug alphabetically and turn to the page it's on.
Awesome. And so that might even be something that you could do in the office with your doctor to get onto your insurance website and say, okay, we decided on this particular medication. Let's quickly look at your formulary and see if it even has a chance of getting covered or not, or what their alternatives are.
Yeah, I think that's great. Realistically, we understand that offices are still busy and that there are still patients waiting to be seen too as well. This is just a part of that healthcare process. So this is something that needs to be done. It doesn't necessarily have to be a provider that's doing that with a patient. If there's an MA, an LPN, a nurse on staff or something like that, they could actually sit with the patient as well and just kind of glance through that. Many times in the medication access field, once a nurse or whoever's in that care coordination role does this frequently, they learn these plans a little bit more. So you may actually have someone on staff who is able to say, I already know that we're not going to be able to get that covered under your insurance. But again, it's just that open communication and that being able to educate each other, as well as having that understanding that this is something that needs to be looked into more. It's not as simple as just being able to say, we want to write this medication and you're going to get it tomorrow. That's the big deal, is that I think there is this assumption that medications are very easy to get, and that if you can get your blood pressure medicine overnight, basically sometimes, why can't I get my specialty drug? There's a big picture that's not really tapped into a lot. Whereas I personally don't feel like it's always the patient's role. It is nice to include them in that and just, again, educate around the time restrictions that are involved, and that it's not the same as just going and picking up any other drug over the pharmacy counter.
For patients, the biggest concern is that their medication is going to get denied. And can we talk about what the common reasons are that a medication may be denied?
Sure. So one of the big reasons that we see a lot of is that the product or the medication itself would require an authorization. So if there is not an authorization on file, many times that medication will be denied. Another huge reason is the lack of medical necessity. Now, this is where the provider role comes in hand very well. Patients don't always know how to justify their medical necessity. So this is where getting those office notes from the provider and really being able to look into detail on why the medication is being prescribed is super helpful for that. Step therapy. Step therapy is huge too. So a lot of times patients will be required to try additional drugs before they're given that one particular drug that might be prescribed for them. This can kind of come down to brand name products versus generic products, or just something that's not on their formulary or on their covered drug medication list, which again is a huge denial reason, a non-formulary product or something that's just strictly not covered. And when we say covered, I do like to reiterate that a little bit. So the word covered is kind of a dangerous word in healthcare. People hear the word covered and they assume that means that someone's going to pay for it. When we say the word covered, we're not necessarily just speaking financially. We want to say it's allowed. So your insurance allows us to perform that service or allows you to get that product. It may not be covered at 100%.
And I think we actually just went through a lot in that answer. And so I'd like to go backwards and just talk about, you called it an authorization. And I know in a previous episode, we've called it a prior authorization. So when we're talking about a prior authorization or an authorization, what exactly does that mean?
Sure. So the prior authorization is, I guess you would almost call it like a pre-approval notification. So insurance companies would require the provider's office to submit what they would call an authorization or a prior authorization. Those words are sort of interchangeable at this point. And it is an overall reasoning of kind of why that product needs to be given. So it's going to be the demographic information, the insurance information, the dosage and frequency. All that's going to be labeled in this prior authorization, as well as any justifications. So it's going to let you know any kind of previous tried and failed medications, a history in general. Why is this medication important to be prescribed? We always recommend that people upload office notes to those prior authorizations as well, just to, again, justify the cause in general. So that is sort of all done before the medication is even offered to the patient at the pharmacy. So basically, if the authorization gets denied, that prior authorization, it's going to be that the insurance company is letting you know that they don't see a reason that that medication needs to be prescribed.
Yeah. And I think that the main thing with this is that a prior authorization does not mean that the doctor just says, oh no, this patient definitely needs the medication and that the insurance company is going to give it. When we've determined as a doctor, when I've told a patient, I think this medication would be good for you, that's me giving it the green light. And then the next green light that needs to happen is through the insurance company. And that's where the prior authorization comes in. And we have to make sure that we're answering all of those questions for that prior authorization, where we have to say, this patient has tried this medication, this patient has tried and failed, which means that they've tried it and they didn't do well on that medication, or that they've had a condition for X number of weeks or months. Sometimes that's a part of the prior authorization process. So there's many random facts that they might want us to fact check and make sure that all of those boxes are checked. And so that's why a lot of times providers may even call the patient back and say, can you just let us know, has this happened? Has this happened? Have you tried this? And that's why it's really important for patients to just have bookkeeping on what medications they've tried, how long they tried it for, the reasons that it didn't work for them, because that helps us as doctors be able to give the insurance company as much detail as possible to try to help get that medication approved. But at the end of the day, it is the insurance company that has the last say. It's not the doctor that has the last say.
No, I think you're exactly right. And that's a great point. One of the things that we also reiterate on the prior authorization side is that an approval would be for a certain time frame. So you may be approved for a medication for 6 months or a year, and then that authorization would need to be reauthorized or done again. And most of the time when we do that, you need to be able to justify that the medication is working. So this is where that documentation is key again. We would just reiterate to the patient to always tell your provider anytime something good is happening, that you're feeling better with the medication or anything like that, so that they can appropriately document it so that you won't have delays and issues later on throughout the year or even the next year.
When we're talking about all of this prior authorization, how much does the patient do? How much does a doctor do? So how much do I as a patient need to worry about documentation, about calling my insurance company, about making sure my doctor knows everything that I need? Or is it all my doctor doing it? So what is the balance so that I know as a patient how to navigate this?
Again, great point to bring up. For me personally, I think it's a great teamwork effort. Patients should not be submitting their own authorizations. They should not be doing that side of the actual work. That is 100% on the office and office staff, I guess you'd say. So the provider and their healthcare team. What that looks like is, again, this is a very time-consuming process. Prior authorizations in general, again, you have to look at the volume of patients that's being done also. This is becoming a more and more common thread. The authorizations are needed for the majority of medications that we use, especially for specialty medications or biologics that are for patients with chronic illnesses. So when we say what is the patient's responsibility, again, I think it's always great to have the patient educated to be proactive in the aspect of understanding their own insurance, right, and their own coverage policy. that individually is not something that the office or the provider would have on hand. They're not going to know what the patient's coverage options are until they investigate further. So if the patient knows right off the bat that's not a product that's going to be covered under my plan, that would help the provider to be able to make better medical decisions as well. When it comes back to it, though, the time restrictions, I kind of harp on it a lot. The majority of our offices have designated people in this role. So these are full-time positions that someone is only doing medication access. That's huge, especially in healthcare, whenever we are used to being able to have people who are able to help in office, help with the provider on the floor in a hospital. But now they're being pulled to only do this medication access prior authorization side as a full-time role. So that just kind of give you an overview of the time restrictions it takes. Providers in themselves, especially when it comes to the denial side, this takes up a lot of their time. That's time away from hands-on care with patients. This is paperwork, and I hate to say it like that because it is still very important. But this is something that from the payer side or from that insurance company side, you're exactly right. They have the final say in this, but we can battle these a little bit, right? We can write these letters or these appeal letters, medical necessity letters, to see if we can get this overturned. But that is a burden for the office. That is a huge burden on the provider and for the office staff, because they then are pulled away from, again, additional job duties. Just have to sit down and really dig this stuff out, investigate it. It can take anywhere from someone who's really good and understands a patient's chart inside and out, may be able to do it in a few minutes or so. But we have appeals that can take us a couple days to write, let alone when you're waiting on that approval. Appeal approvals can take much longer than the actual prior authorization denial that comes back.
Yeah, and this is all time that a provider is not getting paid for. And I just want to emphasize that this is a big flaw in our medical system, and it's contributing to provider burnout because we want our patients to get the medications that they need. And somehow now that job of working through all of this paper trail that the insurance companies have created has fallen on providers. And that's really something that needs to be changed. But until it is changed, the message that I want to give to our community is that you really, as Dr. Bill Anderson said, you really have to give the provider's office a lot of grace because this is work that we are doing at night, between patients, early in the morning. This is all on our time during lunch. This really isn't dedicated time or paid time to do.
Yes. And I can understand people or patients getting apprehensive to want to either start a therapy, just the potential, if they're already on therapy, to maintain that therapy. There are some other options that could be available to them, though, because like you said, this is something that is almost out of our hands, especially once the prior authorization has been submitted. We're at someone else's mercy at that point. So I think that brings up a great point, is be patient, right? As much as possible, be patient. It's great to follow up with your providers when it's been an adequate amount of time to make sure that something, again, our schedules are busy and sometimes we do have a little bit of an area where we need to be reminded that we have something on our to-do list. And sort of, again, that education up front, be clear with the patient on, you need to allow us this many days or a week or 2 weeks before you may hear back from us regarding this medication.
And also sometimes the provider's office doesn't hear back that a prior authorization is denied. So it is sometimes helpful to get a phone call from the patient saying that I wasn't able to get the medication, because sometimes we feel that we've done our part and that the patient likely has the medication. So it is true that sometimes we don't even realize that the medication hasn't been authorized and that there is something that hasn't gone right in the process. So it is okay to follow up with the doctor's office or to make a follow-up appointment through telemedicine and discuss what are the next steps.
Yeah, no, I think that is a brilliant point as well. Because like you said, so this kind of goes back to that teamwork side, right? If you receive a letter at home that looks odd to you and that you're not understanding what it's being said, it's a great time to reach out to the doctor, make an appointment, and kind of go in and walk through that letter together. I think it should be something that's considered more of a best practice. Set up a telehealth appointment and let's go through this together and not just assume what it says. Multiple times I get emails or things like that that say a portion of a letter, but is not really the in-depth portion that I need to be able to understand it better. that denial letter sort of serves as our instruction manual, right? It kind of gives us the next steps and what the denial was.
Yeah, and I love the idea of doing a telemedicine visit to really review what the denial looks like and why it looks like the insurance company is denying, because that gives us an opportunity right there and then to discuss with the patient and have them help us say, oh, no, no, no. I actually did try a medication like that from this time to this time, and this is why it didn't work. And that way, the doctor can, in that moment, while they actually have that time set aside for you, write down in your note and document that this patient did try that. And that's going to be a part of that medical necessity portion that would go into the letter that we would have to write.
Can I quickly summarize what we've talked about? Because I think this is a lot. So what I'm hearing really that's important is that your doctor is doing a lot of work that you don't realize they're doing, because they're doing more than just sitting with you at the appointment. They're documenting all of this. They're sending all of this to your insurance company. So you need to be clear with your doctor about what that timeline looks like. Ask them, when should I contact you again if I haven't heard back from either you or my insurance company? What can I give you to help you write to my insurance company this pre-authorization? So it really sounds like you need to be very clear in communicating with your doctor, both your timeline and the history of what you've done before you've seen them, so that you can make this first step easier. And then if you get the denial letter, call your doctor, set up an appointment so that you can go through the next steps. And really, it sounds like half the battle is admin.
Yeah, I agree with what you just said. It is kind of, I still kind of harp on this teamwork side. It is both sides' sort of responsibility, and I hate to use that word, but to kind of communicate together.
So denial is the big thing that we're worried about. And so, Lacey, can you just one more time give us a rundown, a list of things that are going to happen when a medication is denied and what that appeals process looks like?
Yes. So walkthrough of the appeal process in general is reviewing the denial letter and understanding what that denial letter means. Why was my medication denied? After that, the next step you want to do is contact your provider. You want to reach out to them, let them know that you received a denial letter and what it's being shown. Set up an appointment, whether it be via telehealth or coming into the office to review that actual letter. Be sure you bring it with you, or be sure you have it available to be able to show. And then gather all that documentation. While you may have a healthcare team behind the scenes that's helping to navigate this appeal process with you, don't take it for granted. Any kind of office notes you have, any kind of lab work, get a copy for yourself and keep a copy so that you have access to this stuff as well. That may also help push things in the right direction. If there is some sort of, if you have an office that does not have that extra support, then you already have this documentation available. If you're confused, if you don't understand what any of it means, call your insurance company and ask for a more clear definition of what is needed to get this overturned and why there was this appeal to begin with, and have them really kind of narrow it down into the overall reasoning. Sometimes it's extremely simple, but documentation on paper can be scary. Sometimes it's just as simple as, we needed your lab work. So just call and ask the question, and don't be afraid to reach out to someone else. After you do that, there needs to be a actual formal appeal submitted. Again, hopefully your doctor's office is able to help you kind of navigate what that appeal letter looks like. If not, create a letter kind of justifying why you needed to be on this medication, and be able to provide all that documentation along with it, showing where you had tried and failed multiple other medications, and any kind of justification that would help to sort of turn that into your favor. After we've submitted the appeal, we're waiting. The insurance company should give you a roundabout timeline, whether it be 72 hours or whether it be 14, 15 days. They're going to give you a time frame. If you have not heard back anything within that time frame, follow up. Call back and make sure that it's not something that got put on a desk or put somewhere and accidentally overlooked, because everyone in the world is busy right now. So we want to make sure that people do not lose track of what's actually on the plate to do. Once you followed up, again, we're still waiting on that decision. So we take note of the time frame. We just continuously keep that on your radar. I'm really big about putting it in a calendar. I can go about and live the rest of my life. I'm not going to let it overwhelm me. But then when it comes to this date, I need to follow up again if I haven't heard anything. If your appeal gets denied, you can file for a secondary appeal. Don't just submit the same letter. And again, that second denial letter is going to give you the reason and sort of that overall instruction manual on what you need to do next. Look at the reason why it was denied, talk again with your provider, and really set up a plan on what you could do next to get that overturned. In this meantime, one of the great things to do is also reach out to your provider to see, are there samples available for me? Or is there any type of program to where I don't continue to get denied this drug, but I also have a great quality of life? I can continue on my therapy and not have a delay in care. So those are sort of the main steps to keep going with. And then once you get the approval, great. Things have been overturned. That's wonderful. If for some reason it comes back and you cannot get it approved, the next step is to have that sit down conversation again with your provider and see what other alternatives exist. Is there any other kind of program I can get on, a denied savings program or anything with the pharmaceutical companies that would offer me more products for throughout the rest of the year while we try to figure this out? Or do we need to switch products to something that's a little bit more either affordable or covered under my insurance?
Yeah, and that's why the sample programs are really important. And so, if it is taking a long time, or even right off the bat, depending on the medication and the need for the medication, a lot of these pharmaceutical companies do provide the provider samples, which means medication for the patient to try. And so, that's another thing that you should look into to see if that's an option for you. And then sometimes they even have something that's called a bridge program. Lacey, can you explain to patients what that is exactly?
Sure. So bridge programs are, like you said, they are offered by the pharmaceutical company, and they are typically give you a certain amount of medication in the interim while you're working on a prior authorization. So this can be up to, it's typically usually up to 3 months worth of medication, because again, that kind of gives us that leeway to be able to work on what's going on and have plenty of time to get it back. And what this medication is it's a free medication provided to the office to be able to give the patient, or provided directly to the patient, depending on how the provider chooses to allow that patient to get the medication. But it's also one of these things that we like to harp on, that just because you are on this bridge program, it's not going to last forever, and your medication may not always be at $0 cost. It is definitely, it's a wonderful feature that's available through most pharmaceutical companies at this point to help decrease that delay in care while we're still waiting for the admin work to be done.
Yeah. And I think that the nice thing about that is if the patient does do really well on the medication, then that's even more ammunition against the insurance companies if they're trying to deny. If the patient goes from feeling very poorly and not doing well to doing much better on the medication while they're receiving it, then that's something else that we can talk about when we're trying to appeal their denial.
So this sounds like a really overwhelming process for a patient because, I mean, if you think about it, you think that you're going to go on a medication that's really going to help you, and then you have to navigate all of this craziness that could happen, that you get denied, and then you have to figure out this bridge program. Other than a really good relationship with your doctor and getting on the phone with your insurance company, is there another resource that a patient can tap into that will help them navigate all of this? Because honestly, I personally get totally overwhelmed by insurance, and I feel like I'm probably not the only person, right?
No, I think you're exactly right. Just what you said, how it can be extremely overwhelming for the patient, it's extremely overwhelming for healthcare workers who do this on a regular basis. So I can't imagine living in that world on a regular basis and then feeling that you needed to navigate it on your own. Your number one resource is going to be your provider and your healthcare team. That's really the number one go-to person. Now, there are some people who are kind of faced with an unfortunate dilemma of not being able to have that extra support with their provider's office. At that point, what can you do? So there are organizations like NAMAPA that exist out there, and we do provide resources that help to understand that process in general, kind of like a guide of this is what you do next. But on top of that, we have what's called the Medication Access Network. So a patient can reach out to us and say, I'm having a hard time getting my medication filled, and I'm not understanding what the next steps are. We can have an experienced professional then reach out to that patient and help guide them. We can't submit things for them or do anything like that, but we can help guide them in the next steps based off the information they're receiving from their insurance company.
And is that a free service that's provided to people?
Mhm.
That's wonderful. And so somebody can get all of their documents together and then sit on, I'm assuming, a virtual consult and go over everything and figure out what can the patient do next to help that process along.
Yes.
And I think that's the special sauce of your company, right? That's the key thing, because I think there's a lot of information online, but to actually have somebody that's a specialist be able to sit down with your particular case and review it with you and then give you your personal next steps, that is gold to me in this whole process, because I think it really would be so helpful.
Yes. And I think it kind of comes back to that standpoint of we've all worked in the office before. We know how overwhelming this can be. And as healthcare has grown, this medication access side has gotten very large. Prior authorizations are required a lot of times now that they didn't used to be. So the rules have changed a little bit. So I think just being able to have an additional resource that exists out there for those patients, particularly who are not able to get some additional help at the office or some extra hand-holding to navigate that process. I would never expect anyone to understand how to do this stuff step by step when it's something very new to them particularly.
So that was a lot of information. Lacey, is there something positive that we can take away?
Yeah, of course. Remember, denial is the worst case scenario, right? They do not always happen, which is great. There are multiple times. I mean, I would say I don't even want to call it 50-50, but there are occasions where your drug is just approved. Again, these are things that can be worked on. The denial is not a stop sign. It's not just a hands down, we cannot get this and we're not going to move forward with it. It's just we need to look and see what the next step is. So it's not a big red flag that says you're done with therapy. It can just mean that we need to work further. I mean, I hate to say don't let it get overwhelming. I know it can be. Don't let it control your thoughts. Because again, if the denial stands and that answer is a no, then there is a different way. And so there's a different product. There's something different that exists. There's a lot of options available. So we can always help to navigate that and reach out to other people to see if we can get you what you need.
I love that. And I think that the major silver lining is that organizations like NAMAPA exist and are trying to help navigate this process and make it easier for patients and providers. So I think that that's the silver lining. And that's why I was so excited to talk to you. And you've provided so much helpful information. So I'm excited about our next conversation that will help close the loop, where we talk more on the provider end and easy steps to make that process easier for the provider.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.